Got it.
Thank you again. Now I'm starting. Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference. My name is Hasan Kamil Sucu. I am the program manager of the neurosurgery department of İzmir Training and Research Hospital. This online education program goes on with the contribution of all the residents, also with the contributions of the neurosurgeons who graduated from the same department, our department. I can ask you to keep your microphones turned off during the presentation to avoid voice and noise pollution. You can ask your questions not by turning on your microphones, but writing to the chat part of the program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please do not ask for your microphone to be turned on. And now I would like to introduce our guest. It is my privilege to present our lecturer, Professor Stephen Honeybul. Mr. Honeybul was born in 1962. He is a British-Australian neurosurgeon. He graduated from Bachelor of Medicine, Southampton University in 1995. He had his fellowship of Royal College of Surgeons degree in 1998 and fellowship of Royal Australian College of Surgeons degree in 2007. He continues his studies as consultant neurosurgeon of statewide director of neurosurgery, Western Australia. Mr. Honeybul is head of the Department of the Neurosurgery of Royal Perth Hospital, Sir Charles Gairdner Hospital, and Fiona Stanley Hospital, Western Australia. In 2009 and 2014, he studied as member of Western Australian State Committee of Royal Australian College of Surgeons. In 2014 and 2015, he studied as Deputy Chair of Western Australian State Committee of the Royal Australian College of Surgeons. Since 2012, Mr. Honeybul is examiner of neurosurgery in Royal Australian College of Surgeons. In 2015 and 2017, he studied as a chair of Western Australian State Committee of Royal Australian College of Surgeons. And since 2020, Professor Honeybul is chief examiner of neurosurgery in Royal Australian College of Surgeons. Mr. Honeybul has lots of clinical research and over 100 publications. He has book chapters in several books. Mr. Honeybul is author of 2 books. One of his books, named Ethics in Neurosurgical Practice, was published in August 2020. And the second book, named Traumatic Brain Injury, Science, Practice, Evidence, and Ethics, was published in September 2021. Mr. Honeybul was invited as speaker for many national and international conferences. And today, Professor Honeybul will talk about decompressive craniectomy. Mr. Honeybul, Professor, the screen is yours. Please start your screen sharing. Okay, you can turn on your microphone again. You can turn on your microphone.
Ah, there you go. Right, give me a second. Good. Can you see that?
Yeah.
Excellent.
Perfect.
Well, thanks for your kind words, and thanks for the invitation. Looking at the online contributors you've got and the library you've got, it's a real honour to be invited to talk to you. So I'm going to talk about an inconvenient truth about decompressive craniectomy. And it's fairly established it's an aggressive intervention with significant morbidity. It will not reverse the effects of the pathology that precipitated the initial crisis, whether it be stroke, subarachnoid, or in this case, trauma. There's no doubt now it reduces mortality and increases survival with severe disability. And the ethics around that. And I'll finish up by looking at the disability paradox as it pertains to survival with severe disability. And just as a background, for those of you who don't know Australia, I'm from Perth, which is the most isolated place on the planet. And I trained in England, in the UK, and that's my catchment area of 2.3 million people in Australia. And where I trained, my catchment area in the UK was 3.4 million. And you look at the normal neurosurgical situations, many hospitals refer patients in with trauma, and then they go back to those hospitals for rehabilitation. And the long and short of it is many people do not really have a good understanding of a long-term outcome following traumatic brain injury. That was Weymouth. I used to think Weymouth was a long way away. These are the distances on a similar scale to Australia. And in West Australia, we only have 2 neurotrauma hospitals, very close together, most of them at Royal Perth. So we have a very good idea of the long-term outcome of these patients. People don't leave Perth very easily. And we have a good data collection, so we know what comes through the door. And you can see that this is the number of decompressive craniectomies we've done over the years, and it is slowly reducing, I think. Although we still do it as a primary procedure or as a secondary decompressive procedure for raised intracranial pressure. And here you can see the absolute numbers and a tendency to doing more for primary decompression following evacuation of a mass lesion, as opposed for intracranial intracranial hypertension. And the questions I'm sure all of you have faced, this sort of situation here, young man, severe traumatic brain injury, a very bad scan, intractable intracranial hypertension despite maximum management, and a very bad scan indeed. And the question remains as to what you feel about this outcome at 18 months. Is that a good outcome? And does it justify the intervention? And traditionally, the way to analyze this is by clinical trials and the traditional pyramid of evidence, which places background information and expert opinion at the lowest level of evidence. And I think that needs to be challenged these days. Another way of looking at it is to accept the results of clinical research, and we'll go through that in a minute. But that has to be interpreted with expert experience, I believe. And you have to understand the pathophysiology of the disease you're treating to understand why certain treatments are never going to work and apply them appropriately. And I'll go through those one by one. And in the context of traumatic brain injury, I'm going to go through some of the background information, which you have to appreciate, I believe. You have to have a degree of clinical experience to appreciate and criticize what's being presented to you. You have to have clinical research. And in TBI, patient preferences are another important factor that needs to be considered. So in terms of key concepts, it's important to understand 2 key concepts in the context of TBI. There's a neuroexcitatory cascade, the so-called excitotoxicity cascade, and the Monro Kellie doctrine. I'm sorry, this is a bit basic for some of you. This is just a contextual example of one of the many cascades that begin at the initial trauma and are accelerated thereafter. So when you have a severe traumatic brain injury, a large amount of glutamate and a neurotransmitter gets released into the extracellular space. A lot of that goes straight into cells and immediate cell death. Nothing you can do about that. But that this excitotoxicity continues in the minutes, hours, and days thereafter, and causes so-called collateral damage, apoptotic cell death. The so-called pro-survival genes are turned off. And again, slow apoptotic cell death, collateral damage to cells that might otherwise have survived, which is why a brain that looks like this when it's normal, dying from acute injury, and someone who survives a TBI, you often see this severe cerebral atrophy. And again, I don't think you can give any talk on TBI without mentioning, first of all, primary prevention. This is the excitotoxicity schematically demonstrated. And I'll now show you a scan, which I think is one of the most important pictures in TBI, because when I first took this picture 15 years ago and I put it up in a TBI conference, no one said anything. If I put it up now, I'll get a response within 2 seconds. And the response is no helmets. And that to me is the biggest advance in TBI over the past 15 years. You wouldn't dream of skiing down a black ski run now without a helmet on. 15 years ago, it was a regular thing. That's a huge advance, I feel. And again, that's me in Tasmania 3 years ago, halfway up a very picturesque mountain. That was day 2 in Tasmania. That was day 1. So that was a 60-kilometer head-on collision, which I walked away from. So again, I can't emphasize enough the need for primary prevention. But everything we do in TBI is really aimed at preventing secondary insults, because we know that drives the excitotoxicity and causes raised intracranial pressure. So everything we do is aimed at preventing this cycle occurring. The second key concept is the Monro Kellie doctrine, which you all know. I won't labor, but the brain's in a rigid box with glial tissue, neuronal tissue, blood, and CSF. Normal ICP. When the brain starts to swell, blood and CSF start to get squeezed out. ICP starts to rise and then becomes catastrophically, rises catastrophically, and the patient eventually dies. So let's just go through a few examples of therapeutic options. And again, I ask this question of the residents very often. A typical patient brought into hospital, obeying commands, but a GCS of 11, intubated for transfer, and we'll get asked all the time, do we put a monitor in, and why do we put monitors in? And I use the example of what's called the 3 Ps, prediction, perfusion, and pathology. High ICP is an independent predictor of poor outcome. We can use it to perfuse the brain, as, looking for the ideal CPP. And again, it monitors for the development of pathology. But the question we've had for years around ICP monitoring and the management of ICP, does the absolute control of the number improve outcome? And again, here we can see that same sort of patient, initially ICP of 15, overnight increases to 40. We can do all these things, but we repeat the CT scan and pathology has developed, these contusions have matured. If there is no pathology and it's just raising ICP, what options do we have? And again, I'm going to go through hypothermia, not so much thiopentone, but then looking at decompressive craniectomy. Because again, certainly when I first started out 25 years ago, we used these measures routinely. But again, have we shown that decreasing the ICP, the absolute number, improves outcome? Again, hyperventilation used to be routine. It certainly isn't now, but it used to be routine. And how does it work? Well, it causes cerebral vasoconstriction. It lowers the ICP by reducing cerebral blood volume. The last thing the injured brain needs is less blood. Likewise with barbiturates, there's no doubt barbiturates do lots of things to the neuroexcitatory cascade, but how do they work? Well, they lower metabolism, lower CO2, lowers the ICP while reducing cerebral blood volume. And again, we used to use barbiturates routinely 15, 20 years ago, use them very rarely now. And what about hypothermia? And again, exactly the same thing, really. Lowers your metabolism, causes vasoconstriction. And again, these studies go back to 1954. Now, the concept of hypothermia was good. The idea was that all this excitotoxicity would be slowed down on a blanket barrier level. And there's no doubt much work has been done looking at how hypothermia can be neuroprotective by affecting this cascade. The difficulty is no study has shown any benefit in terms of neuroprotection if the target temperature is not obtained within 2 hours. And the clinical evidence is there now, very much so for hypothermia. Pediatric trial 2008 stopped because of higher mortality in the hypothermia group. Clifton studies, I'm sure you all know these, no benefit. And the most recent, very recent Eurotherm study, no benefit. And if you look, if you nut into the details of this, this is why you have to have some degree of expertise in interpretation. If you look here, 35% mortality in the hypothermia group, 26 in the control group. So worsened outcome. And again, hypothermia, just a tendency towards worsening, increasing mortality in the hypothermia group. Does that mean we don't use it at all? Not really. But this is an interesting study here, an interesting appraisal here saying the progression from animal to human studies has been criticized as overly hurried and possibly over ambitious. So I'm not sure, I'm not convinced that hypothermia is done and dusted, but we had to be wary of the fact that as with other therapies that lower the ICP, it comes at a cost. So what about decompressive craniectomy? Surgical indications as a secondary procedure for raising intracranial pressure, intracranial hypertension, as a primary procedure when following evacuation of a mass lesion or following stroke. And the evidence is now there for efficacy. So let's dissect that a little bit. Because there are 4 real questions you want to know about decompressive craniectomy, or I've been trying to work through over the past few years. Is it a life-saving procedure? Does it improve outcome? Are there risks associated with it? And what are the indications? And certainly 15 years ago, many people believed it improved outcome. And many people, and this is very often intensivists, didn't really appreciate the morbidity of the approach. So is it a life-saving procedure? Well, in the context of stroke, patients who develop malignant middle cerebral infarction have a very high mortality. I'm sure we've all seen that. And in the early 2000s, there were 3 European trials independent in looking at outcome. And because of difficulty with randomization, they pooled the analysis of these 3 trials comparing decompressive hemicraniectomy with standard medical therapy in patients under 60 years of age. And these trials independently confirmed a dramatic reduction in mortality from 71% to 22%. So again, the results here back in 2007, conservative, black is death, dramatic reduction in mortality. More recently, in terms of for TBI, the Rescue ICP trial published in 2012, again comparing decompressive craniectomy with standard therapy plus or minus barbiturates. And again, fairly clear here, black is death, surgical group, reduced mortality. So I think it's unequivocal now that decompressive craniectomy is a life-saving procedure. I think we've known that for years. But the big question is, does it improve neurological outcome? And again, as with other therapies that we've seen, bringing the number down does not necessarily improve outcome. The absolute control of ICP does not necessarily convert it into an improvement in outcome. And again, how do we assess outcome? Well, in context of stroke, we use the modified Rankin scale and dichotomize outcome into favorable or unfavorable. The implication being that we're trying to obtain a favorable outcome. In TBI, it's the extended GOS, Glasgow Outcome Scale, and again with a similar dichotomy. And the difference between favorable and unfavorable is essentially the patients that are independent to some degree. So when you look at the results of the hemicraniectomy trial, using that dichotomy, you can see conservative treatment, red is severe disability, okay, surgery appears to increase your risk of survival with severe disability. However, if you change your dichotomy, and you'll see this very often in medical trials, if you change your dichotomy such that modified Rankin scale is favorable, and I think that's debatable, your results will look better. If you extend that degree of analysis a little bit further and look at patients over 60 years of age who have a hemicraniectomy for middle cerebral artery infarction, and this is where it comes down to, I think, the degree of expert analysis, or you really examine the conclusions that are presented to you. The conclusions were that hemicraniectomy increased survival without severe disability. Okay, is that correct? 63% of those in the hemicraniectomy and 53% in the control group gave retrospective consent. This result should be interpreted with caution, given that 25 of the 42 survivors could not adequately answer a question because of severe aphasia or neuropsychological deficits. So amongst the 47 patients who had a hemicraniectomy after middle cerebral artery infarction in over 60-year-olds, 20 died, 3 had a modified Rankin score of 3, so independent, 51% modified Rankin score of 4 to 5, and 34% of those patients, a third, could not answer a simple question about whether they would have that done again because they were severely dysphasic. I don't really see in my own mind how you can justify that conclusion. What about evidence in the context of trauma? Well, again, surgical group here, using the traditional dichotomy of unfavorable and favorable, comparing the medical and surgical, as an almost direct conversion of survival with severe disability, increase in mortality or decrease in mortality and survival with severe disability, almost directly. So you're saving people's lives and they're remaining dependent. You can change your dichotomy to have upper severe disability as a favorable outcome, and your results look slightly different, but not statistically relevant. So does decompressive craniectomy improve neurological outcome? I used to say maybe not. I think the question now is no, it does not improve outcome. It reduces mortality. So are there risks associated with it? Well, if you go back to the DECRA study, this looked at early decompression to lower the ICP and improve neurological outcome. It's a good trial, widely misinterpreted, I feel, because the aim of the DECRA trial was somehow to block off effects of secondary insults, early decompression to reduce the ICP, to prevent the development of these cascades and stop raised intracranial pressure. And again, what it showed was that early decompression meant you were operating on people you would not ordinarily operate on. And it was criticized because it said that these patients were not representative of neurological usual neurosurgical practice. But if it had shown benefit, we would be doing far more decompressive craniectomies. So it was a good line in the sand to make us reconsider and just not assume the fact that lowering the ICP by surgical decompression was beneficial. And what it basically showed, well, if you do this to somebody, expose their frontal lobes bilaterally, that's a damaging procedure. It'll lower your ICP, but that's not converted. As with hypothermia, as with barbiturates, as with hyperventilation, that lowering the ICP, the absolute number, is not necessarily converted to an improvement in outcome. So are there any risks associated with it? Yes, it's increasingly appreciated now that there's morbidity with this procedure, and just lowering the ICP is not necessarily beneficial. I'm not sure what it's like where you are, but the intensivists used to give us a lot of grief about doing early decompression, assuming it was improving outcome. So what are the indications for surgical decompression? Well, I collect the data in WA, and you can see here we have fairly big numbers in terms of secondary decompression, primary decompression, and secondary from the unilateral swelling. And these are the circumstances in which we use it. The ICP, as explained, the ICP is 25 to 26, despite therapy that far exceeds maximum medical management. Well, in these situations here, again, this goes back to 2012, ICP up to over 40, not responded to paralysis, supersalt, head up, thiopenta. And again, we still use these measures as an emergency when we think people aren't going to survive. And in these circumstances, a considerable number of patients at 18 months actually have a good outcome. It's this category that I think is problematic and debatable over a 16-year period. A significant number of patients who survive with severe disability. Because there has to come a time when the injury is so severe that you have to think about not intervening. And I've used the crash outcome prediction model, which is based on the data from the crash study that looked into steroids. And this model here you can log into on the web, and you can fill in the country, age, GCS on presentation, whether their pupils are working, and major extracranial injury, yes or no, and that factors in hypoxia and hypotension. And that'll come up with a prediction of unfavorable outcome at 6 months based on the crash study and their outcomes. And you can see here, major extracranial injury factors in hypoxia and hypotension. The risk of unfavorable outcome, and unfavorable is severe vegetative or death. That gives you the number. As your age goes up, the number goes up. So it's just an injury severity score, no more than that. An injury severity score at the time of the injury. And there are obvious limitations to that. If you have your scans available, again, you can plug in your demographics there. If all you have is a few petechial hemorrhages, your risk of an unfavorable outcome is relatively small. As your scan gets worse, as we all know, the risk gets higher, and it just quantifies the risk for you. You've got a very bad scan, you can see the risk there. Now, is that useful clinically? What you can do, and I've done for a number of years now, is compare the prediction of an unfavorable outcome with the observed outcome. And these are the absolute numbers of patients. So if, say, for example, of the 20 patients that have come through with a prediction of 21 to 30%, so not a particularly severe prediction, 18 of those patients had a good outcome, 2 are moderately severely disabled. As the prediction goes up, i.e. your injury severity goes up, so your observed outcomes reflect that. And is that clinically useful? Well, let's take a couple of cases. 19-year-old male, GCS of 8, 1 blown pupil. Again, ICP 40 despite maximum medical management. Bit of subarachnoid blood. Basal systems are patent, small petechial hemorrhage. Again, he's run out of options in terms of ICP control. He has 53.2% of those factors that contribute to an unfavorable outcome. So bad, but is it that bad? Well, of the observed outcomes of the patients in WA, the observed outcomes are 18 months in the patients who've come through WA with a similar injury severity score. 36 had a good outcome, 8 moderately disabled, 3 severe, 7 patients died. So it would be hard not to offer that person decompression based on those observed outcomes there. Slightly more severe injuries, we all know. Again, loss of basal systems, midline shift, some petechial hemorrhages and some contusions, and non-evacuated hematoma. ICP 40 plus, should we decompress this person? They've got 72.9% of those factors that contribute to an unfavorable outcome. And so what can we tell a family about the outcome, or the most likely outcome? Well, in these circumstances, we can genuinely say we don't know. We cannot predict, because that's right in the middle. He may die, he may have a good outcome, maybe moderately disabled, maybe severely disabled. Hard not to know what to do. That's a genuinely I don't know situation. And finally, let's go back to our first example. Again, an 18-year-old male, fixed a pupil at the scene, second pupil fixed in the emergency department. Well, we know that's a bad scan, and we know that person's in a lot of trouble, but you can quantify that now. 93.6% of those factors that contribute to an unfavorable outcome. And the observed outcome in patients that have come through Perth with a similar injury severity. Again, in these circumstances, you can't dichotomize outcome into life or death, because if he survives, there's hardly any chance of him getting back to anywhere near normal. Statistically, there will be a green there eventually. There has to be. But the most likely outcome if he survives is dependency. And again, it's not the ethical or the legal aspects of this, it's more how we feel as a society. Certain parts of the world, you cannot consider not intervening. Other parts of the world say, no, that's not the way we do things here, and we would not offer decompression. And it's not for me to say, it's not for me to have that judgment. It's people feel very differently about survival with a severe disability and the acceptability or otherwise of that outcome. And can we have a philosophical discussion about it? So that's my bias. I think to myself, I don't think converting death to survival with long-term disability is a good thing to do personally. However, just to finish off, there's a concept of the disability paradox, the fact that doctors are generally very poor at looking at or assessing quality of life, looking at their patients and going, I would never want to live like that, etc., etc. Whereas actually patients with severe disability often report a very high level of satisfaction with their outcomes. And has that been demonstrated? Well, yes, I'm afraid I almost shot myself in the foot a little bit in a relatively small study done nearly 10 years ago. And I'll be honest with you, I was genuinely hoping to demonstrate that patients who survived with severe disability were not happy with their outcome. That was the point of the study, to confirm my views, which were actually wrong, to be honest with you. What we did was, we took amongst a cohort of patients who'd had a decompression between 2004 and 2010 in Western Australia. That was amongst 186 patients. Now, amongst those patients at 18 months, 34 patients were severely disabled and 5 patients were permanently vegetative at 3 years. And we got those patients back beyond 3 years. So at 18 months, 34 were severely disabled, 5 were vegetative. And we got them back beyond 3 years to reassess them. And again, to assess quality of life and to see if they'd improved or not. So all patients had survived beyond 3 years. 7 of those patients, of the 39, had died. 12 were lost to follow-up, and so we had 20 patients who we could reassess beyond 3 years. And it was an independent study by occupational therapists, a structured interview, either in their nursing home or in their own homes, and a number of assessments: the extended Glasgow outcome, the caregiver burden interview, and the SF-36. And we asked them a number of key questions. We asked the patients whether, looking back, they would have given consent for surgery based on the fact they had survived with severe disability. And we asked them, how well could you remember what you were like before your injury? The implication of that is that they were so disabled they couldn't appreciate their former life, and the relevance of that or not. We also asked the next of kin a number of questions about were you asked to provide consent? Was there mention of severe disability? Was it mentioned that there was a possibility of severe disability? If you'd known your relative would have had this outcome, would you have provided consent? And knowing your relatives, you knew them before, would you think they'd be happy to be the way they are now? This is a little bit messy, but this looks at all the patients in the study. And the thing here is all patients were still either vegetative or severely disabled. So beyond 18 months, no one recovered beyond severe disability. So this is the short form 36 mean normative data. And this was quite striking, really, because it confirmed that all patients remained physically disabled, and the mean would be in a normal population would be 50. So all these patients remained very physically disabled, but their general health and vitality, mental health and mental scores were near normal. Okay, so these people were not saying they were having a dreadful outcome. They felt normal. They felt good. This was not always the case, and this is just the mean scores. And this is another interesting slide, looking at their designation, which surprised me a great deal. This is patients beyond 3 years. Many were home with their wife, parents. So families have made huge changes to their circumstances to get their loved ones home and to look after them. And you can see the carer burden was quite mild in a lot of cases. Not always the case. One person here felt very bitter about the whole thing and was putting her husband into a care home and felt a severe burden. But again, how often it is just a mild degree of burden for getting patients' loved ones at home. And that surprised me a great deal. I did not expect that. So again, at the time of your injury, we asked the patients, for those who could provide a response, and that obviously biases the responses somewhat. Looking back, would you have agreed to have the surgery before me, knowing your eventual outcome? And I fully expected most patients to say, no, I would not want to be like this. And again, I got it completely wrong. Most patients who could provide a response said, yes, I would provide consent to survive, no matter what. And you can ask the question, how well can you remember what you were like prior to the injury? And is that actually a relevant question to ask? Because just because you're disabled doesn't mean your life's any less worth, has less worth attached to it. But again, that was a slightly grey area. do people feel they were given sufficient information regarding the possibility of long-term outcome with severe disability? Oh, I've got that wrong, sorry. Yeah, most people thought they were not given enough information. And again, if you had known that your relative would have had this outcome, would you have provided consent? About 50-50. So whilst the patients themselves felt they were happy with the outcome, the relatives were less sure about this, about 50-50. And again, if you knew your relative as you knew them before, would they be happy with their outcome? And again, that's more 50-50. So that surprised me, because that is a disability paradox. The fact we're looking at patients who are surviving long-term with severe disability, and most are accepting of that outcome, which is an interesting finding. I did not expect that. Was their quality of life acceptable after decompressive surgery? Had they adapted or recalibrated to an outcome which we feel would be unacceptable? That's a possibility. There are limitations to this study in that 5 patients were in a vegetative state, and there's no way of knowing how they feel about it. And 12 patients were lost to follow-up. So it's hard to say really, because some of them may have found their outcome to be unacceptable. But from an ethical point of view, this is written by Grant Gillette, who we've written a number of papers about. It's about making the decision at the time, which has some degree of closure, whether it's to intervene and say, look, there is a possibility of survival with severe disability. And when you make that decision, that you may derive some comfort for the fact that actually it has been demonstrated that most patients who survive with severe disability actually do tend to find it acceptable. And likewise, when you decide not to intervene, you have to base it on some degree of evidence. So is decompressive craniectomy a life-saving procedure? Yes. Does it improve outcome? Probably not, and I'd say no. Are there risks associated with it? Yes. And I think, I'm not sure what it's like with you, but very often the intensivist will be pressuring us to do decompressions in circumstances where you go, I'm not sure this is a good idea. And just taking the bone off is just not just a bone operation. It has significant morbidity. What are the indications? And it depends. It depends what you're trying to achieve. And I think I'll call that quits at that stage. How long has that gone for? Yeah. Thank you.
Thank you so much, sir. Professor Honeybul is the first Australian speaker in our online conferences. I want to thank you again so much.
Thank you very much.
And I'm directly passing through the questions in the chat part. Dr. Selim Bozdağ from Kastamonu, Turkey, asked a question. It's quite long, and I want her to ask personally. Okay.
Thank you, Professor.
You're welcome.
Sorry. Can you hear my voice?
Yes.
Yep.
I listened presentation without my losing my curiosity. Thank you. What do you think about sinking flap syndrome, a rare complication after large craniectomy? Do you have experience with such a case?
Yes, yeah, a lot. And we actually looked at neurological improvement in the week following cranioplasty. We found a significant number of patients did improve slightly, but there's no doubt that some patients are particularly susceptible to this, and there's a kind of dramatic recovery. And what I find, it's a good question, but I think the other question is, why is it that people can walk around with a big depressed skin in their skull and be relatively normal? I don't understand that. That should affect them more. We should see it more often. But yeah, and that's why we generally try and put the bone flap back as soon as possible. And I'm in close cooperation with our rehab doctors. So if they do find patients either stop progressing or get to a stage where they progress and then start to regress, then we put the bone flap back fairly quickly. But we put the bone flap back fairly quickly anyway these days.
Thank you so much, sir. And there is one more question from Burkay Akta. Also, he was one of our residents. Now he is working in the east side of Turkey. Thank you for presentation. You mentioned, according to researchers under 60 years old patients with MCA infections going for decompressive craniectomy improves survivability. But from our clinical experience, there are more patients with same conditions over 60 years old. Is there a conclusion for those age group in means of survivability?
Yeah, that's a good question. And I think that points to the limitations of using the modified ranking score as an outcome, because that focuses very much on the physical ability to do things. And for example, if you're not independent for things like walking and things like that, and that's actually not the most important thing for a person who survives a middle cerebral infarct. You can be physically very disabled, but cognitively just have a stroke. Dominant hemisphere, I think, is a bigger question, because I think surviving with a dominant hemisphere stroke, if you can't talk, I think that's a very poor intervention. But if you have non-dominance, many patients who are wheelchair bound seem to be, apart from the fact they're physically disabled, which should not be relevant, but they seem to be neurocognitively, they can make a good recovery. So I think that highlights the limitations of the assessment tools that we use.
Thank you, sir. And Professor Bektaş Açıkgöz from Turkey. Thank you, Professor, for the excellent presentation, he says.
Thank you.
And Dr. Baran Taşkala from Istanbul, Turkey. It was a great lecture. Thank you, Professor. Dr. Baran Taşkala, Başakşehir City Hospital. And Dr. Christopher, he didn't write his country and affiliation. Thank you, sir, for the presentation. I would just like to ask your experience regarding malignant MCA infarction with hemorrhagic conversion, 1 week post-ictus. Do you still advocate for surgery after the patient deteriorated? Thank you.
Again, yes, in non-dominant strokes. I would say in a non-dominant stroke, that brain is dead anyway. So yes, I would advocate. In dominant hemisphere, I think that's a different discussion altogether. I don't think patients who can't talk have a particularly good quality of life. So yes, I do advocate for. And again, that's another limitation of the methodology, and the fact we tend to focus on the stroke trials that use a very fixed cutoff point of 48 hours or 96 hours. I don't think in clinical practice you can be that dogmatic about the timing.
Thank you, Professor. And there is one more question. I want to repeat that. Please write your country and affiliations when you are writing a question in the chat part. Brian Soberon from Philippines. Do you advocate decompressive hemicraniectomy after evacuation of ECH, intracerebral hemorrhage, in a deteriorated patients, low GCS, 4 to 8. Do you
That's a hard.
advocate decompressive hemicraniectomy after evacuation of intracerebral hemorrhage?
I think once you've taken the hematoma out, in most cases, I think it's relatively safe to put the bone back. And I tried to put the bone back as much as possible when considering any situation where the brain's swollen, whether it's a tumor, because you commit that patient to a second procedure of cranioplasty. So whenever you can avoid surgical decompression, I do. So if I took a clot out and I could safely put the bone back, I generally do that.
Thank you, Professor. I think all the questions and comments are finished in the chat part. Anyone who wants to make a contribution or comments? Okay. I think all is finished. I want to thank you again one more time, Professor, for joining us, for accepting our offer to speak in our conference. Goodbye.
Goodbye. Thank you. It's an honor.
Bye-bye.
Thank you very much. Okay. Goodbye all. See ya.